This is a case about a 40-year-old gentleman who had the privilege of serving. He's a U.S. veteran. One of my biggest passions is taking care of U.S. veterans, and this gentleman had all the history of a veteran. He is a para-jumper, so he's recorded over 100 jumps, and he'd retired from his service. And I would say he was a Marine, but you're always a Marine. He's still a Marine. And he's still a very athletic gentleman after his past training, so he actually functions to his dreams to be a professional athlete again. He's very, very good. He has a very healthy spine overall. You know, up to about L4, it looks outstanding. It looks like a young man's spine. But once you get to L4-5 and L5-S1, there was a lot of pathology, largely from the impact of his para-jumping and his athletic endeavors. So at L4-5, he's got a spondylolisthesis. He had pars defects that never really troubled him over the course of his life, and so they were treated conservatively. And at L5-S1, he had a very large herniated disc. So he was tremendously impacted in terms of his quality of life and his comfort from the pain of the spondylolisthesis and the degenerative disc, as well as radiculopathy. And ultimately, he came to me for care at Veterans Affairs Hospital. I thought about, long and hard about how I would treat him. I think, honestly, I would have treated him much differently in my training than what I do now, and Flarehawk has offered me unique solutions to help him. In my training, I have to confess I would have probably done a lateral and an A-lift because I loved the emergence of those technologies. I loved the fact that we had big footprints. They honored the fundamental principles of fusion. You had big cages full of bone surface contact. You had good contact surface apposition that could fill with graft. But there were also some problems with those technologies. Number one, you didn't have gold standard bone graft. You had to use highly expensive solutions. And the corridors they had to traverse were sometimes dangerous. You had to go through the vessels for an A-lift. You had to go through the lumbar plexus with these really large cages for a lateral. So really the reason I chose Flarehawk here was in the quest to be the most thoughtful in how I would treat this person. Being a gentleman in his 40s, I didn't want to do an A-lift because the risk of retrograde ejaculation or high blood loss would have been very detrimental. And the lateral corridor, while it seemed attractive, number one, I'm working at 5'1", so that wouldn't have worked out. I could have used it for 4'5" because the crests were low. But the problem is this gentleman wants to be an athlete. And as a former athlete, your first step is everything in sports. I could not induce psoas trauma and let myself live with that because if he lost his speed, he lost his future. So really the goal was to try to find a way to treat him from a posterior corridor. And I moved away from the posterior corridor because unfortunately, although you could fixate very well from the back and you could directly decompress from the back, the anterior-most portion of the spine couldn't be well treated historically because the PLIF and the TLIF were so outdated. Well, Flarehawk represented an opportunity to actually bring those up to speed. So now I could treat the inner body space with a wide footprint cage. I could fill it full of the best product possible, which is the patient's own natural autograft. And I could completely decompress the nerve roots with an implant that expands once it crosses the neural elements. So unlike the other A-lift and lateral cages, this implant actually honors not only the fundamental principles of fusion by being large and expanding and having good contact surface apposition, which is what everybody agrees upon as being the fundamental tenets of fusion, but it also honors the fundamental principles of implantation. It stays small until it crosses the neural elements. And so that's why I chose Flarehawk in this case. He's a young man. I wanted one position surgery. I wanted to get him off the table as fast as possible. And to me, the most MIS thing you can do in this world is limit the amount of time under surgery and the time under anesthesia. And so that's why I went that route. So ultimately, I placed 4 Flarehawk implants. I basically did a PLIF at L4-5 and L5-S1. And the reason was to give him basically a lateral size or anterior size cage from the back, to confer the immediate stability you get with a broad footprint, and then be able to fill that with a high volume of natural bone graft to where I wouldn't have to incur the cost of high dollar biologics. I did that in the inner body space. As I got to the neural space, I was able to completely decompress him with bilateral facetectomies, which is what he needed, especially at the spondy level. And then when I got to the posterior fixation, I didn't have to compromise there either. I was able to fixate him with good, robust pedicle screws. So to me, the Flarehawk implant, as it stands now in the posterior corridor, represents the ability to treat the patient in every portion of the spine, the inner body space, the neural space, and the posterior elements without any attempt or need for compromise in those segments.